Okay, so the plan is, I know Kishore and them, they use some of my slides from last term, some of the questions, but they're really good questions. So I'm gonna quickly go back through those just in case. I want y'all to be good with all of the pedigrees. We'll go through that and then we'll take a break and then we'll hit the last week y'all did. We'll do a lot of the autonomics, do some of the high yield stuff with the drugs and stuff. So we'll try to keep it about 2 hours. That's the goal, but depending on how many people have questions. But hopefully by the end of this, y'all will be set up to date and then you can move forward. Yeah, if y'all been with me before, y'all know I like to, by the time the next week starts, ideally, everything from the previous week, you kind of caught up, right? You don't want to have too much because there's no extra time. You may have a day or two before the exam. So we want to keep y'all up to date with the material. And for FTM, we like to make these PowerPoints and these reviews question-based because you need to get into the mindset of answering these style of questions. There is an art to it. It's like anything, it's like sports. The more you do it, the better you get at it, the faster you get at it. You know, there's definitely a science to not just knowing the material, but how do you answer these questions? So we're going to kind of run you through how we walk through the questions when we do them, things that we think important, you should cue into your mind, like, okay, I see what they're saying there. Okay, that's important. The age is important in this one, you know, like things like that. So that's the plan going forward. Lindsey, you ready? Should we start? All right, cool. Let me share my screen.
I'm going to monitor the chat, guys. I just put this in there. I have some videos that I really enjoyed for autonomics. They're pretty simple, but they kind of helped me conceptualize it. So I'm going to find those and put the links in the chat, but I'm going to monitor the chat in case you guys have questions.
Okay, so y'all know I run Scrubs, Lindsey's a dog mom, so all of our information can be accessed there. We put stuff on our Google Drive, stuff that we use during your term that we found helpful, whether it be old questions, old tables, just stuff. You know, a lot of it is too much to actually all go through, but if you find something you like, by all means use it. If nothing else, old questions are great, right? More questions you do, the better you're gonna do. All right, Dr. Sobring updated these videos. If you haven't watched them, they're just little, you should be able to access these links on your copy. They're just little clips of him going through the different disorders. But we're gonna teach y'all what you need to know for the test because the problem here is you don't have a whiteboard, which is kind of it's kind of a give and take because the questions have to be easier. Like if you don't have scratch paper. So take that as a good thing. You know, but anyway, you can watch these videos, you can see how they go, how he likes to teach it. A lot of things are, and we're going to go through this, it's like you have to make assumptions, but you always want to assume what's the most common situation. You don't want to assume both parents are autosomal dominant, right? With a pedigree, maybe one person's autosomal dominant and the other parent that you don't know about is typically normal. So you don't want to assume anything that's not given to you, but we'll get into that in a second. Okay, first, I want to talk about the allele frequency versus the genotype, right? So when we look at the equation P plus Q equals 1, we're looking at the allele frequency, right? So the allele frequency should break down in this way. If you see MM is going to be 64, that is our homozygous normal. Our heterozygotes is going to come out to 32, and that's what we're called. The M is an allele and the N is allele. You get one from each parent. The NN is going to be the diseased allele, if we're assuming, for any case. So this is going to be how it breaks down. And if you take this and plot it, you would get about 80% alleles of the M type or the normal type and 20% of the disease type. Okay, so that's important because this is going to give us our P plus Q equals 1, meaning if you have P, then you could solve for Q. If you have Q, you could solve for P. And this comes into play when we do some of the equations we're going to talk about. So you could see that here. Now, the other way to do this is when we break down to see who is actually the homozygous normal, who are the heterozygotes, and who is recessive for the disease. So by solving for P, again, you can solve and find out what's Q. So basically, in either situation, whether we're looking at the alleles or we're looking at the genotype, you can figure out by just having one what the other one is. And that's the whole principle between Hardy-Weinberg. Now we can go a little bit further. This is a little bit more of the same. This is from first aid, just a caveat. This is the first book I always open when I'm looking for something. It's kind of the Bible. So anything you want to know, if you want to know, is this high yield? Do I need to know it? If it's in first aid, consider it high yield. Not a lot of excess facts here, but it will give you the bare bones stuff. Lots of good mnemonics. So always go there. I try to incorporate this into my slides because it's just good for you to start looking at. The sooner you start looking at, the more comfortable you'll get with it. Okay, so I did mention this. So P squared is going to be our homozygous. Heterozygotes are going to be the 2pq, and homozygous recessive are going to be the q squared. So that's all going to equal 1. And as I said, if you solve for one, if you have one, you can solve for the other. So this is going to be our genotype, right? And that's going to work out for this. Now, this is what's important for solving our equation. So if we're looking for the incidence, we're going to have the incidence in a population, and we want to solve for Q. So if they tell you the incidence is 1 in 10,000 people, what is Q? This is the equation. Now, I'm going to walk you through how I do each of these, but by all means, star this slide. This one's the most important, okay? Because Dr. Sobrik, it just works out. The test questions you're going to have, they're better written if they're autosomal recessive. They kind of test, it's like an umbrella way of testing knowledge underneath it. And it gets a little bit complicated when you do it with other stuff. So if the questions you're going to get on the exam are, when it comes to the pedigrees and working out the math, will probably be autosomal recessive. So what you want to know is if you take the square root of the incidence in the population, you can solve for Q. If you get Q, you can solve for P, right? Okay, and this is just from the notes, same thing. Q equals the square root of I. Now, if we're looking at the autosomal recessive carriers, right? They're not showing a phenotypic variant, they're just carriers. We're looking at the middle number, the 2pq. And that makes sense because these are heterozygotes, so they're gonna be carriers. And if you work this out, Q is gonna be 1/2 times I, or I over 2. Same principle here. Now, I'm gonna go through this kind of quickly since this is last week's material and we wanna get to the new stuff. But autosomal dominant is gonna be the same thing, right? Because as it works out, hold on one second. I think I'm running, yeah, give me 1 second. I have it like with transitions and stuff, but I sent the one y'all have. I was using the one you guys got. All right, yeah, there we go, that's better. Okay, okay, so autosomal dominant works out like this. So if we assume P is still the homozygous normal type, so Q is going to be our disease type. Technically, we're looking at the disease because anybody that's heterozygous for an autosomal dominant mutation is going to show the disease, right? Because they just need one. It's autosomal dominant, disease allele. Now, you're also going to see this Q squared in that very small fraction of a population where one person with the autosomal dominant disease has a child with another person with the autosomal dominant disease, and that 1/4 chance they have a child that's actually homozygous for the normal mutation. That's going to be your Q squared. But as Dr. Sobring explains it, this number is basically negligible for 2 reasons. Mathematically, it's just not that likely to happen, okay? And also, when you think about the genetic problems that happen, autosomal dominant problems, I mean, they're pretty severe because you can get it with just one allele. So if you have both alleles messed up, a lot of times those patients or those children, it's not compatible with life. So what we're going to do is not worry about this number. The number's negligible, makes the math so much easier. So what it works out to is the same as the autosomal recessive carriers, right? It's just whether it's autosomal recessive or dominant, but we're still going to look at that 2pq variable. And if this math is a little jumbled or I'm speaking too fast, I'm going to break it down on one slide in a second. So now let's look at the X-linked recessive. Because the men are hemizygous, meaning they only have one X, right? One X, one Y. If that one X that they have is diseased, they're gonna have it. They're gonna have the disease, right? That's all they have to work with. So you can actually use this equation, the P plus Q equals 1. So that's gonna be whether they either have the disease, or excuse me, the Q would be the diseased X or the possibility that they have the normal X. So in this situation, Q is going to equal I. That's how it works out. If you wanted to do the female carriers, right? So they have 2 X's, assuming 1 X is mutant, we're still, again, going to use this 2BQ. Okay, and this is just the way the math works out. Technically, I'm just showing you how they came to this slide that's coming up, which is this one. It's blue, it's pretty, so know it. But this is how this works out. But what I just explained is why the math works out the way it does. So by all means, you definitely want to know this top one, okay? Because they're going to give you those sorts of pedigrees. And remember, you don't have a scratch paper, so you should kind of have a general understanding of the basic square roots, right? You should be able to know that, be able to do that with a simple calculator on ExamSoft. So a lot of that I explained before is kind of just to get to this point. So by all means, know this stuff right here, because this is what you're going to use when you do the incidence rates, and you'll be able to figure out, depending on what type of disease genetically it is, you could figure out what Q is. If you have Q, you can solve for P. All right, let's see. All right. Maybe just read over this slide. It kind of helps in certain situation when they talk about the which of this the Jewish population, the Ashkenazi. That's terrible. But the Jewish population, you know, that you can kind of clue into your mind that it's Tay-Sachs disease, or the Northern European, or the areas in Africa that are endemic for malaria. Okay, so it may not be necessarily like you would have to know it, but it will be an extra bit of information that'll help you come down to a point where you can help to solve the problem. So just know that some certain populations have endemic diseases that are more frequent in the people around there. Okay, so now when we do these math problems, we're going to use the same principle every time. We want to figure out the dad's risk times mom's risk times the Mendelian frequency. The Mendelian frequency is going to be like, well, if it's autosomal recessive, then it's a 1/4 chance you get it. It's autosomal dominant, it's going to be 1/2, right? So and so this is what we're going to do. So always when I do these, I say, what's dad's, what's mom's, what's the baby's, or what's the frequency? Okay, blue slide. So I would commit these rules to memory, because without scratch paper, Dr. Sobring's going to expect you to know these rules. Okay, because, and we're going to do a problem with it too, because if you notice these in the stem, you could just say, okay, that's 2/3, that's 1/2. You don't actually need to draw out the pedigree. So he is going to expect y'all to know this. Okay, so let's take a look at this one.
Are we directing our answers to you, Brady, or to Lindsey?
Yeah, either way, y'all could just direct message. Y'all could just direct message to one of us. Either one, that's fine. All right, so for the most part, people are getting it. It's going to be 1/12. So let me break it down to where, like, how you should be able to do it on the exam. So let's pull this out here. Family history shows that husband has a brother. The husband's brother has a daughter with cystic fibrosis. So this guy's niece has the disease. So you need to ask yourself, what rule is that? So if we actually go back, if you have a sibling, a brother, sister with a child with the disease, you're at 1/2 risk. Perfect, right? 1/2 rule. Now, so this is dad's husband. So we got dad's, check. What is this? Wife has a sister with cystic fibrosis. due to a defect in the same gene. His wife has a sister with cystic fibrosis. What's the rule? If you have a sibling with the disease, wife has a sister, you have a 2/3 risk. Perfect. We have moms. Now we have dads, and now we have moms. So dads is, let's see, moms was 2/3, dads was 1/2, and it's autosomal recessive. So the chance of the child having the autosomal recessive disease is 1/4, comes out to 1/12. So basically, you could do this fairly quickly. If you notice in the stem, sisters with the disease, a niece with the disease, something like that, you should be able to know these quickly. You don't have to draw it out. Okay, let's try this one. So let's see. Okay, so this will be dad. He's from the normal population. Mom is, what's mom got? She has a niece who is a known carrier. Oh, this makes it a little trickier. So that works out to 1/4. So if she has a niece that's a carrier like this, then there would be a 1/2 chance that the mom gave it to her. Right, so that'd be mom and dad. And this person of interest is over here. Right, so there would be a 1/2 chance that this is the child. There'll be a 1/2 chance mom gave it to her. And if you look at the parents, then there's a 1/2 chance the aunt got it too. So you multiply these through and it's 1/2 times 1/2. This may be a little bit, would be more difficult than he would ask you, but just know that you need to multiply through the population. If you're still a little confused, I did put in green underneath the question, a full explanation on it. But the point is, if the child is big A, little a, there's a 1/2 chance that the child got it from mom, and a 1/2 chance mom got it for the child got it from dad. All right, and the same thing works for the niece, for the aunt and the mom who are sisters. There's a 1/2 chance they share 50% of their DNA, right? Okay, so mom equals 1/4. Okay, so let's figure out dads. Remember, to take this, we know it's autosomal recessive. So we're gonna take the square root of 1/3600, right? So that's going to be 1/60. Okay, because remember the incidence Q is going to equal the square root of the incidence, correct? Because it's autosomal recessive. Okay, so if you take the square root of 1/3600, you're going to get 1/60. Now here's the trick, and I used to always forget this. You're assuming that the dad over here is a carrier, not with the disease, okay? So that 1/60, you have to multiply it by 2, okay? Because you want the carrier frequency. You want, so this, then you're gonna go, you actually wanna solve for 2Q because that's the carrier frequency. So 2Q equals 1/60. So Q is 1/30. Now, I got a little busy there. Let me clear it and I'll show y'all one more time. All right, so we know that for autosomal recessive, we're gonna do Q equals the square root of I. We know from this 1 in 3,600, the square root Q will equal 1 over 60, correct? Because we took the square root of I. But we want to solve, we want to know if dad is a carrier. So what we want is not Q, we want 2Q. We want to know if he's a carrier. So 2Q is what we're solving for. So if 2Q is 1 over 60, then Q equals 1 over 30. I promise you, they'll put the wrong answer in like the wrong answer with you doing it like with 1 over 60 on the test, because Dr. Sobering will do that. He wants you to remember you have to multiply by 2. So whenever you do this incidence, make sure you know that at the end of the day, you want to solve for 2Q, okay? So dad has to be a carrier. Don't forget that. You always have to do it. Always, always. Okay. It's just one of those things. Yeah, sure.
So what's the buzzword that will make us multiply by 2? Is it that the husband's from a population is where the incident? Oh, we just always do it more. We always do 2Q.
Yeah. Because you're assuming that the dad's a carrier and the mom's a carrier. You want the carrier rate, right? When we solve for mom, she has a niece who is known carrier. When we found that 1/4 for mom, that's saying mom has a 1/4 chance of being a carrier. Okay, that's what you always want to say it like that. 1/4 chance mom has a carrier. So we need to see dad's chances of being a carrier. So you always want to multiply by 2 whenever you do the incidence for the autosomal recessive. Okay, so that's about as difficult as it could get. Again, as I said, if you want a little more clarification, I put the explanation in green on your slides. So yeah, this is how it should work out. 1 over 30, because remember dad's rate, 2Q. Mom's is 1 over 4. And then the Mendelian frequency, autosomal recessive, is 1 over 4. All right, let's try this one. Okay, so basically, this is a tricky way of saying, okay, so we want to see if this child is going to end up being DR4 and DR3, right? So if this child ends up being that, that's not good, according to the pedigree. So it kind of works out like an autosomal recessive pedigree, because you can assume like this is one allele from the parent, this is the other allele, this is one allele, this is the other allele. So it's going to work out the same. So let's take a look. Right, so basically it's autosomal recessive. So if there's a half chance here, you get it. So let me break it down this way. Whoops. Okay, so we're just worried about this guy here, right? So what is the probability that this child will get DR4? Half, right? Half a chance, 50% chance you get the 4, 50% chance you get the 8. What about this one? Same thing, right? For this, for the mom, 50% chance you get that, and 50% chance you get the DR7. So we know dads. we know moms, and then we know the Mendelian frequency. So by doing that, we have our we know our equation, right? So 1/2 times 1/2 times 1/4, and that will equal 1/16. So it's kind of a different way of saying autosomal recessive. Okay, let's try this one. All right, so the allele frequency for this specific allele is 1 in 400. So Q is going to equal 1 in 400. It's not the incidence, right? We're not saying the incidence, we're saying what is this allele? So that's telling us what Q is. So remember, we want to say Q squared equals I. That's the same thing as saying Q equals 1/2 I. That's not an I. There's an I. That's a good I. All right, so this is what we're looking at here. So what we're going to do is just multiply 1/400 squared equals this one right here. Okay, so that is the chance of you finding a homozygote in the population. If the allele floating around is 1 in 400, the odds of two people coming together and them having a child with both Q squared being homozygous for this allele would be 1 in 160,000, which is why this frequency is so small. Yeah, it's the same thing as saying P squared. Either way, yeah, you could do it either way. It's the same thing.
Brady, can I ask a question quick?
Yeah, sure.
Yeah. So how about if I use the Q is equal to 1/2 I? That should give me a different answer compared to the 1600. I mean, I got the answer correct, but I'm thinking if I use Q is equal to 1/2 I, that should give me about 1 over, I think 8 something.
Sorry, Q. I wrote that wrong. My bad. Yeah, sorry. So Q is gonna, if you square it, you have to take the square root of I. Yeah, thank you for correcting me. It's not. Yeah, sorry about that. But that it's correct on. Oh, that's not right. Here we go. Yeah, so this is the same thing. Sorry, this works out to this. Obviously, if you square 1, you take the square root of this is the square root of this. So this is how it should be. Okay, so this is for this recessive thing, for this recessive or homozygotes for this 1 in 400 chance of having an allele. So you can see that here. So 1 in 400. So we have Q. We want to know what the incidence is, right? So we're saying, what is the incidence of Q squared? What is it, right? Question mark. So you have to, so by having Q squared, we could figure out the incidence, this homozygote incidence. That's what we're solving for. Now you can also ask yourself, well, what if we were looking for a carrier? What would we do? So if we know Q is 400, they told us that, right? So P would be, if we, well, let's just leave it at that. So we could solve for, like we did before, we could solve for Q squared to find the homozygotes, right? And that's where we got this 1 in 160,000. But we could also solve for the carriers, right? How many carriers do they have? And this is similar to the last one when we had the father and he was a carrier. You remember you have to multiply by 2. So same thing, you just plug in the 400. So 2 over 1 in 400 equals 1 over 200. Okay, so just remember what they're asking you for. If they're asking for homozygotes, you're going to use either P squared or Q squared. We're assuming this is the disease allele, so we're just going to use Q squared. If you're looking for the carriers, you have to use the middle number. So the same thing works out. It's all that same equation, the Henderson-Hasselbalch equation, P squared plus 2PQ plus Q squared. Okay. Now we're going to move on and do the lac operon, everybody's favorite from undergrad. So we'll touch on this briefly. This is a tricky question for it, but go for it. Okay. No, there's no QR code for this. This is not affiliated with DES. So we run these on our own, which is why we can record them, and we will post the recording later. But this is not affiliated with DES. Lindsey and I just do this on our own weekends. Okay, so the question you need to ask is there any point in which something is going incorrectly? Okay, so let's just break it down. In the presence of glucose and lactose, should this be working? Right, so this helps. This is one of those portions that helps to break down lactose. If glucose is present, should the lac operon be on? And the answer is no, right? Because the whole point, this is a twofold system, right? The idea is saying 2 steps. One is if you do have lactose present, if you do have lactose, we want to transcribe everything that's going to break down the lactose. But if there's glucose present, we don't want to bother with lactose because we have glucose. Let's use the glucose we have first. Once we run out of glucose, then we'll deal with the lactose. So this is a twofold problem. So right away, you could say, well, if there's glucose present, the lac operon should be off. Why is this being transcribed? And that's the problem we have here. Now, what about the other part it talks about? No protein product is produced when E. coli is grown only with glucose. That's right? If glucose is present, the whole system shut down. You don't need to worry about lactose when glucose is present. So the problem happens somewhere in this step with beta-galactosidase. And as it happens, it's actually the C-amp receptor, that part that binds to the lac operon to turn it off. So I'm going to explain this further here. Okay, so this is our lac operon. This lac repressor here is going to be transcribed, right? Once that's transcribed, if it binds at any point, it's going to turn it off. So if there's no lactose present, this is going to be transcribed. This is going to sit right there on the lac operon. No lactose, Nothing's transcribed. Perfect. We don't want to transcribe all these enzymes to break down lactose if lactose isn't present. Okay, now let's say lactose is present. Well, this stop sign, the lac repressor, is still going to be transcribed, but the lactose is going to break down to allolactose, part of it, and it is going to be able to bind to this repressor. Therefore, it won't bind to the lac operon. So when lactose is present, it's going to be transcribed. So that's step number one. Is lactose present or not? Then you could look at glucose. So if glucose is present, then, if no glucose is present, then this is going to be turned on. So for this to work, you need no glucose, meaning this signal is placed on there. And you need lactose present, which means that stop sign is going to be pulled off. So you need a positive part and a negative part. Okay, so with no glucose present, this C-amp, which is what we have as a problem in the equation, because we actually had glucose, so this shouldn't have been bound. That's what happened in the problem. I have an explanation there as well. But if no glucose is present, this CRP and this C-amp is going to bind together, and it's going to bind here, and it's going to help with transcription, okay? If glucose is present, then this portion, this CRP, is not going to bind. And that's what should have happened, because glucose was present in the question, and so it should not have bound. So this should not have been transcribed, okay? So, and you can look at this here. So you can just ask yourself, first off, is glucose present? Because if you got glucose, you're not doing anything. Secondly, is lactose present? Because if glucose is absent and lactose is present, that's the only time you're going to transcribe it. So you should be able, that question was on the more difficult, on the more difficult side, but this will just break it down for you. So remember that lactose has to do with that lac operon and stopping it if it's not there, and the glucose has to do with that CRP C-amp binding. If glucose is not present, then it'll bind. So you need both components. And it's just an efficient way for the body to be able to regulate this, right? Okay, let's look at this one. And so this will be a fairly quick one on the test. This dimer formation, if you want transcription, you want the mix-max combo. If you have a heterodimer of max-max, it's not going to transcribe. So you want this mix-max combination. This is from your notes. If mix and max come together, actually this one, yes. So this is that max-max combo. Here it's a monomer to, a dimer to mix. And this will be, I'm sorry, of two maxes, right? Two monomers of max come together, they make a homodimer. It won't transcribe. What you want for transcription and cell proliferation is that mix-max heterodimer, and that'll help with gene transcription. Okay, you're gonna see this a million times coming up. Well, not today, but in your med school career. So quickly, we'll look at this real quick. So alpha motor neurons, motor should tell you right away that you're on the ventral side. Yes, definitely memorize this. So the dorsal side is sensory, the ventral side is motor, right? Ventral meaning the front, dorsal meaning the back. So the ventral side is motor. So these ventral motor neurons or these alpha motor neurons are going to be involved with the motor aspect, right? And you'll see in histologically, you'll see these little, they kind of, I don't know, they look like single cell little amoebas, I guess to me, but you'll see them. But they'll point those out in histology. And so you'll know if they give you a close-up slide of these little alpha motor neurons, you'll know you're in the ventral horn, but that'll come later. All right, So yeah, and this just kind of points it out, right? Dorsal, this is gray matter, this is white matter. White matter meaning tracks, gray matter meaning cells, dorsal horn sensory, ventral horns motor. All right, good. Another one. So we're going to talk about the gap junctions. So which side are the gap junctions on? And you should know that the gap junctions are on the lateral side. So the trick here is, okay, so this, if we look, the way I do this, if you see these lines running parallel, right? The lateral component is going to be over here, separating these two. So it's going to run parallel, like it's on the side of it, right? So they're going to run parallel. So the lateral component is parallel to it. So that's where you're going to find the gap junctions. Just think if two cells are next to each other, like, and it's lined up like that, this gap junction can communicate between them. But on the other side, the transverse side, you're connecting them together, right? So that these are on the the basal side or the bottom side. So you're connecting them together. So if you're looking at these, I think there's another picture. Oh, well, it's the same one. If you're looking at these and you're looking which one's the lateral side, just in case they just give you, they just point to it. The lateral side is going to be the one that runs parallel to it. The transverse side, this Z line here, is going to be the one that runs perpendicular. Okay.
Brady, how about one quick question?
Yep.
Yeah, do you think in exam we're going to have an answers? Because I know that the MA, the macular adherence, you know, it is present in both the lateral and the transverse component. So in the exam, are we going to have the lateral and the macular as well?
They could ask you that, and they could say, on which side is it? And they would say it's on both lateral and transverse. So thank you for bringing that up. You can see the macular adherence is on both the lateral side and the transverse side. The fascia adherens, just transverse, gap junctions, just lateral. They could ask you any of these things that are underlined here. Yeah, for sure. Thanks for bringing that up, Frank. All right. So autonomic nervous system. Remember, the autonomic nervous system is very primitive, right? So it has to do with a lot of the visceral movements, the visceral sensations. So this primitive aspect is from the brainstem. Y'all will get into that later, but just a good thing to know and to introduce you into autonomics, which everybody loves. A little bit more, yeah, you'll get into this later. Okay, not a stain used for elastic tissue. You should know this. These are all different names, but different people that made these stains. So this elastic connective tissue can be stained with these, but silver stain is for reticular fibers. Remember, you have, but if you learn anything from SGU, when you're finished, reticular fibers are short, thin, and branching, okay? Silver stain stains them. So be good with that. And you can see that here. These elastic fibers are like this comb appearance here. And if you take a cross section of it, you could see it here. Yeah, so they kind of run, and they, you know, they're primarily a good example is in the aorta, right? Have a lot of that blood that goes through and pulses through. So you have these elastic fibers that help it to recoil. And we'll get into that when we get into CPR, which, by the way, is much more fun than this stuff, I have to say. Once we get into like the clinical aspects of medicine, we'll be good to go. All right, so what we're talking about here, this is actually multilocular, and this is just one of those just kind of quick things you want to be able to recognize on the exam, right? And you can see this signet, these aren't signet rings, but it does have that some of that similar appearance, so be aware of it. Signet ring just means it's kind of pushed to the side, but you can see this this H&E stain doesn't stain fat, right? So this fat is going to get washed out, or the stain is going to get washed out. So you know this is a multilocular. Just one of those things you just need to be able to identify. All right, yeah, here's the signet ring. So you can see they're kind of pushed to the side, these little cells, right? Okay, and they're unilocular adipocytes. And then brown fat, interestingly, is the term too, as we were just talking to them about this. It has to do with electron transport chain, and you're not exactly making ATP, you're kind of just burning heat. And infants have this brown fat, and it allows them to stay warm. Fun fact, bears use this too. They have a lot of brown heat when they're hibernating. So it's just a way of making heat without actually using forming ATP. You're not storing the energy, you're just burning it off as heat. Okay. So what are we talking about? Stabilizing collagen and elastin, okay? What are we talking about here? That's lysine, right? Lysyl oxidase is important in that. Remember, what's the cofactor for lysyl oxidase? is copper. So you need that, and that's going to help with this binding between collagen and elastin. You could see this here. Copper is the cofactor. What's the cofactor for the hydroxylases? Prolyl and lysyl hydroxylase. I believe it's vitamin C, right? So you know that, but remember, you want to keep these separate. Oxidases for this elastic fiber binding. The prolyl and lysyl hydroxylase is for collagen binding, okay? Know your cofactors for sure. Easy test question. All right, scurvy. Gum bleeding and swelling. They may not even tell you it's scurvy, but if you see this for right now, that's what you should think. Pirates actually did get this because they didn't have fruit on the when they traveled the oceans. So they actually got scurvy. So you can remember that. And obviously it's a problem with collagen formation. That's why you get this bleeding gum formation. Yeah, I like that, Michael. I like that mnemonic you put. Yeah, if y'all could see that in the chat, the type to know the different ones, cartilage. Yeah, that's a good one. Yeah. And you can see that here. Yeah, here's our pirate. Right, didn't have fruit. You can see bruising under the skin, and then gum bleeding as well. And it's a problem with this collagen formation. Again, because of the interaction with prolyl hydroxylase and lysyl hydroxylase. Okay, and then this helix formation. Again, this has to do with vitamin C as a cofactor. All right, and this is more like it. As you get along, these questions become more like actual clinical cases, and that makes it more exciting, I guess, to me at least. To Lindsey too, huh? All right. All right, so you want to go through and kind of work this out. Like, what are we talking about? I don't know if any of us will ever see Marfans actually in the clinic. I don't know how. I don't think it's that common, to be honest. But they like to test on it because it has to do with a lot of clinical aspects. So you could see here limb subluxation, possibility of aortic aneurysm. This is why if these children are diagnosed at a younger age, they're advised not to play sports, okay, because of the aortic aneurysm. So you can see this. This is classically a stem talking about Marfan syndrome. So fibrillin is the component that has to do with Marfan, and again, it has to do with that collagen in the specifically in the meat of the vessels, and you can also get this limb subluxation. So crazy story. There was a 7-foot tall guy that got to the NBA. He was drafted, and he actually had a limb subluxation, 7 feet tall. You could look at him and be like, that dude has Marfan's. Never diagnosed as a child, never, right? Gets to the NBA, they screen him. He's got Marfan's. He was about to make millions of dollars. He wasn't allowed to play in the NBA. How did his doctors miss it? SGU would have diagnosed it. There you go. He played at Baylor, actually. Yeah. Didn't somebody say this from Baylor? Yeah. How about that? Yeah, right. So classic, right? Abraham Lincoln, right? I guess he had it. Didn't they say that? That too. Right. So these are classic problems. They get this murmur. They have long, slender fingers. So again, it's just a way of testing. Do you know this fibrillin is a part of the elastic fibers? Okay. All right. Let's get into some of these. This is something that's going to come up again and again. So we're going to work through these. I think first aid is also a good resource to look at these as well. Okay, so what does potency deal with? Km equals potency, which equals your x-axis, okay? Vmax equals efficacy and equals your y-axis. Remember this and you'll be good to go on these, okay? So what we want here is a drug that will decrease potency. Remember, Km is inversely proportional to your affinity. Low Km means high affinity. High Km means low affinity. Just means how tightly it's binding. So we want to decrease potency, right? So if we're talking about A and we want to decrease potency, x-axis. So we're going to go towards B, right? Yeah, right. So, and what we did was, remember, so A is more potent than B, right? Because it has a lower Km. Lower Km equals greater affinity. Okay, so good. So we have a drug now that has a higher Km right here. So, and the Km is actually, it would be right about here. So, and it has a higher Km, so a lower potency, but we don't want to compromise the drug efficacy. So we shouldn't change the y-axis. So B is the same level. So it has the same effect, but decreased potency. So that's what you want to know there. And so the answer, I believe, will be B. Right, okay. And I think I have another, yeah, and this kind of goes into it as well. So remember, if we're changing the x-axis, we're dealing with Km. If we're changing the y-axis, we're dealing with Vmax. The capacity, right, the efficacy, that's what we're looking at here. C can't have as much, right? It doesn't have the same capacity as B. It's Vmax, its maximum capacity or volume or effect will be decreased. A and B have the same effect, it's just how tightly they bind, how potent is the drug. Okay, these are just terms you're going to need to be able to use interchangeably. As for what you need to know, that's a good question. Km and EC50, it's basically the same thing for what we're doing now. They could actually, I don't even know how in depth we need to go with it, but for what I remember, I mean, Lindsey, I mean, we used it pretty much interchangeably, right? Yeah. Okay. Yeah. So yeah, it's the effective concentration at 50%, or the Km is basically about the same thing. But what you're really going to want to focus on is the Km and Vmax. Okay. Again, potency x-axis, efficacy y-axis. So what would D be? It's a question. I wanted to put this on here because it's not exactly intuitive. D, straightforward. D is an antagonist. Some people may say, well, wouldn't an antagonist do something like this, right? That's not the case. An antagonist is only going to counteract the positive effect, right? So the antagonist will always be a straight line. You're counteracting the positive effect. You're dampening or decreasing it or completely diminishing it. So the antagonist will always be straight. This line would be an inverse agonist. You're doing the opposite, an inverse agonist. Okay, so just keep that in mind, some of the nomenclature there. There we go. And you can see that here. See, an antagonist is straight, right? You're just trying to counteract the positive effect. And an inverse agonist will obviously go the opposite way. And we're going to talk about this a little bit more when we get into the drugs and we talk about some of the inhibitors and the muscarinic antagonists and agonists and stuff like that. Okay, let's try this one. Yeah, it might be easier for you guys to direct message Lindsey. It's kind of hard for me to keep up with all this. If y'all want to ask her questions, be easier. Okay, so what are we asking about here? Affinity, right? Affinity, how strongly does it bind? So we said that Km is inversely proportional. So a lower Km means a higher affinity or potency. Okay, so affinity, potency, Km, these are terms that that you need to use interchangeably. All right, and here, let's see, represents an irreversible antagonist. So if we're talking about an irreversible antagonist, you're worried about Vmax, okay? So curve C compared to drug X curve is going to be an irreversible antagonist. I put this on here to illustrate this as well. What graph will also look similar to curve C, and that's a non-competitive reversible inhibitor. And the thing is, when you have a non-competitive inhibitor, it has its own pocket to bind. So regardless of how much substrate you put in the solution, like the substrate can bind, but the non-competitive inhibitor has its own binding site. So there's no competition. So in that case, you can't overcome it with increased substrate. And so you're literally saying you're decreasing the Vmax, right? Your y-axis. So just know that irreversible antagonists and non-competitive reversible inhibitors are all going to work on the Vmax, the y-axis. Okay, again, First Aid has all these terms outlined for you. Make sure you have them straight. If Dr. Trout showed a nice little graph, you could say x-axis is Km, y-axis is Vmax. Where do the competitive inhibitors affect? Where do the non-competitive inhibitors affect? Oh, speaking of, here we go. So this is straight out of First Aid. So you can kind of work through this and see where it goes, what goes where. Okay, let's do this one. Okay, so we remember pH minus pKa will give us this value here. Now, hopefully y'all remember this chart. I have it upcoming. It has the 90, 99, 99.1 thing. Sometimes I get a little confused with like what's going on. Are we on the like 1.1 side or on the 90 side? So I like to do it like this. So if this works for you, go for it. Aspirin is an acid, right? It's telling you that it's an acid. So where would you expect acids to be absorbed? In an acidic environment. What are we talking about? The stomach, acidic environment. Therefore, we would expect somewhere in the higher side, the 90% to be absorbed, not the 1%, right? If it was a basic drug in the stomach, then it wouldn't be absorbed. It'd be on the one side. But if it was a basic drug in the duodenum, in the intestine, then it would be on the higher side. So acids are absorbed in an acidic environment. Bases are absorbed in a basic environment. So if you keep that in mind and you just figure out, they're going to tell you it's an acid, right? It's some sort of acid, it's salicylic acid, right? And you're in the stomach. So you would expect the vast majority of it to be absorbed. And I'll explain that again in just a second. Let me get to the slide. All right, and the proper way of doing it, you say, well, it's just on a test. It gets stressful when you're like, is there hydrogen on it or off it? Is that like positive or negative? But there's, you can figure it out this way. The protonated form will be in the stomach, unprotonated in the intestine. And you just want it to be liposoluble, right? You want it to not be charged. These are the situations when it's not charged. When it's not charged, it can cross the membrane, right? Because it has to cross a lipid layer. Okay, so these are the situations here. And this is the chart. Now, right, so again, if you're trying to figure out on the test, unprotonated, protonated, all you have to say is, if it's an acid in the stomach, you're in this range, right? The high range. If you're a base in the stomach, you're not going to be absorbed, you're in the low range, okay? But by all means, if you want to do it the proper way, you could do that. This way is just a little bit faster. Okay, some math. All right, very good. So let's take a look at this. The half-life's 2 hours. How long has it been? 4 hours. So we know 2 half-lives. So 0.75 is 75% times X equals 6, right? Because that is where we're at. So at 2 half-lives, you use 70% of the drug. We want to know what it is at steady state. So if you work this out, X equals 6 divided by 0.75, which equals 8. It's a tricky way to go around it, but it's definitely testable. So again, the main thing you want to remember, 4 half-lives is always steady state. And this is a good way of using that to figure out. But you definitely want to be able to know these equations and know how to work these out. All right, let's try this one. Yeah, so good. Good, right? So we're saying we're going from 400 to 200 in 120 minutes, in 2 hours. That's our half-life, right? You cut it in half in a 2-hour period. And they want to know at 6 hours. So if 2 hours is 1 half-life, 6 hours is 3 half-lives. So after 1 half-life, you went from 400 to 200. To 2 half-lives, you went from 200 to 100. After 3 half-lives, you went from 100 to 50, right? Keep cutting it in half. First order kinetics as well, right? And I'll mention that in a second. So it works either way. If you're getting rid of the drug in the system, it takes 4 half-lives. If you're trying to get it up to steady state, it takes 4 half-lives. That's the principle there. Same thing, right? Okay, and then when we talk about zero order elimination, it's primarily, you want to remember this, P or APE, however you want to remember it, but these 3 drugs are the ones you're going to want to keep in mind. Phenytoin, ethanol, and aspirin, okay? They're going to have zero order kinetics, which means you're going to get rid of the drug at a constant amount. When you think of first order kinetics, you think of percentage. You're getting rid of a constant percentage. But the problem with zero order is it's a constant amount. So regardless of how much alcohol you drink, you can only get rid of so much every hour, so many milligrams every hour, opposed to percentages, which is why drugs like this have a high, you can overdose on these drugs or be intoxicated quickly. So you want to keep that in mind. So whereas first order elimination is going to be a percentage basis here, yeah, percentage. You're going to see here, this is a constant amount. Okay, let's take a look at this one. Cool, right. So what you want to ask yourself is, what's the loading dose equation, right? And that's what this works out. F is bioavailability. Remember, typically they're going to give you IV drugs. IV drugs have a bioavailability of 1, right? As soon as you give them, 100% is in the body. You don't have to go through the stomach. It's not dampened down. The effect isn't dampened. It's 1 is the bioavailability. So then you just plug it in. And if you plug the values in, 50 milligrams times 2 milligrams will be 100 milligrams. And the explanation I put on your slides as well. All right, this one's a little tricky. Try this one. Now, I think Keisha and them did this question last week too. So we'll go through it a little quickly. So what you need to know, and it may not be intuitive right now, but chronic renal disease, you have a problem with clearance. You can't clear the drug out of your system. So then you ask yourself, well, what equation deals with clearance? And what you'll see is the maintenance dose actually deals with clearance. So if you can't clear the drug as fast, you're going to have a lower maintenance dose. Loading dose has to do with volume of distribution. We're not talking about that. We're asking you, or we're telling you that this guy has a problem clearing the drug out of his system. So if you look at these equations, you'll see that clearance is a component of maintenance dose. This is a tricky question, but I like it because it helps to incorporate the equations into a real life scenario. Okay, blue slide. You need to know these. The most difficult part of the questions that they're going to ask is which equation do I need to use? Because they're going to give you more information than you need. So which values do I need, and which equation do I use? The furthest they'll take this is you'll have to use two equations to solve for an answer, right? So let's say they give you clearance and half-life. You have to solve for volume of distribution, and then you have to plug it in here. Okay, so they'll say you need to use two separate equations. That's as far as they'll go. But typically they'll be pretty straightforward. They know you don't have a calculator, so hopefully they'll just give you straightforward. They like this one too, the clearance, elimination of the drug over the plasma concentration. So just know these, go through practice problems. You'll get better at it by doing that. Okay, we'll introduce a little bit of autonomics. Sympathetics, right? Remember, always parasympathetics. I'll let y'all read it, sorry. I'll go back to the other question after this one. Okay, so parasympathetics, rest and digest. Sympathetics, you're running away from a bear. Now, this situation doesn't exactly go down that road, but that's typically what you're going to see, right? To sympathetics, increase heart rate, you're going to start sweating, your eyes going to dilate, you're running fast. All the parasympathetics, you're chill, you're relaxing, you're digesting. Now, this is a little further than we need to go. I don't know if you need this when you're running from a bear, but this is just good because you're going to have this mnemonic point and shoot, parasympathetics, erection. Penile ejaculation is sympathetic. So you need both components for that. But we'll get into autonomics in a little bit. Let me just go back real quick. So this previous problem was saying the guy had chronic renal failure. He has a problem clearing the drug. We asked about loading dose and maintenance dose. So if you look at maintenance dose, okay, so let's look at loading dose first. Loading dose doesn't involve clearance in the equation. So you would not change the guy's loading dose. You're going to give him the same thing. Maintenance dose, you see, you use dosing rate. Dosing rate has to do with clearance. So clearance is a component of maintenance dose. So he can't clear it as fast. You're going to have to give him more of the drug. Okay. And we'll get into this in a second. I hope y'all have had Dr. Chotts and y'all had these nice little breaks. We'll take a couple-minute break. I'll answer any questions you guys, you had. Let's say 5 minutes, and then we'll come back and we'll do this week's stuff. Okay. So autonomics is one of those things that you just need to embrace, okay? It comes up again and again all the time. It's just super important clinically. So this is kind of your first introduction to it. So basically, we're looking at the body on a more of an automatic level, right? These are not somatic sensations. These are not voluntary movements. What are the organs doing? Are they contracting? Can you feel this pain? So when we talk about parasympathetics versus sympathetics, they're almost like an on-off switch, or do one thing or do the opposite thing, right? So like I said, sympathetics are very much running away from a bear. You know, you want your eyes to dilate so you can see well, you get tachycardic, your heart rate will go up, you may start sweating, a lot of those factors. And then whereas parasympathetics, you're resting, your heart rate goes down, you're digesting, stuff like that. You're able to go to the bathroom, things like that. Obviously, you don't want to go to the bathroom when you're running from a bear. It's an ideal situation. So now, one of the things they like to test on, just to know, the sympathetic fibers have a short preganglionic neuron and a long postganglionic. A ganglion is a cell body outside of the central nervous system. Okay, so you're going to find cell bodies inside the central nervous system. If it's outside, it's called a ganglion. So they're like little checkpoints, right? So this like I said, sympathetic, short preganglion, long postganglion. Opposite for parasympathetics, they're going to have a long preganglion. Sometimes the ganglion that they meet here is going to be at the organ level. So they're going to have a short postganglionic neuron. Okay, so just keep that in mind. That's an easy test question if you know that. This is from first aid, just kind of a little explanation. When we talk about these parasympathetics, we're primarily talking about acetylcholine. If we go back a second, well, actually I have, okay, no, actually, let me tell it here. So at this ganglion level, the autonomic ganglion, it's always going to be acetylcholine. But with parasympathetics at the target level, it's going to be acetylcholine. Sympathetics at the target level, it's going to be norepinephrine, right? Epinephrine, adrenaline, sympathetics, you're running from a bear. All right, just keep that in your head, keep all these together, and it'll help you. All right, so let's look at this. Now, this is from first aid, probably one of the most helpful things I'm going to tell you today. These right here. Now, you need to go through and kind of understand the general idea of what's going on for each of the receptors. But if you remember, y'all learned that the GQ receptor runs through IP3 and DAG to go to protein kinase C to increase calcium. You're going to want to remember that. So the mnemonic, if you put it down here, alpha 1, alpha 2, beta 1, beta 2 is KISS, QISS, and then muscarinic is kick. Okay, so when we talk about the sympathetic nervous system, the adrenaline, the running from a bear, we're thinking about your alpha and beta receptors. Okay, when you're talking about cholinergics or muscarinics, you could use those interchangeably. You're talking about these M receptors. So they could ask you very simply on the test, alpha 1 receptor or beta 2s, what is the downstream product, you know? And you know, beta 2s falls in the GS category, so you're going through the protein kinase A pathway, right? And I have a slide to illustrate that as well. But just remember these, so you should be able to correlate. Alpha 1s is GQ, alpha 2 is GI inhibitory, and both the betas are GS. Muscarinic is kick. Okay, and this will help you understand the different. Because there are a little variances. As with medicine, nothing is straightforward, nothing's black and white. There are always kind of gray areas. So they like to test on those, unfortunately. This may help you. Beta 1s for the heart, 1 heart, beta 2s, 2 lungs, right? So when we talk about beta 1s, the primary effect is going to be your heart. For the beta 2s, if you think about albuterol, for people with asthma, it's going to be a beta 2 agonist. It's going to bronchodilate. So if they get some sort of reaction and it closes their bronchi and they can't breathe, they could take that beta 2 agonist, that albuterol, it'll widen up or dilate the airways, and they'll be able to breathe better. A little trick, and this comes to play when we talk about epinephrine. So vasoconstriction is going to be alpha 1, vasodilation is beta 2. It gets a little complicated, but for right now, let's put it this way. At low levels of epinephrine, basal levels, what you're working at right now, you're going to be vasodilated. You start running from a bear, you're going to get increased levels of epinephrine, and you're going to start vasoconstricting. What ends up happening is you get vasoconstriction on some of the internal muscles, or excuse me, the internal organs such as your gut, because you don't need blood flow to your gut, and you're going to get vasodilation to a lot of your extremities because you want that aerobic respiration, you want oxygen, you want to be able to run as fast as you can. So just remember, low levels, you get beta 2 effect, vasodilation. higher levels, you can get this vasoconstriction with alpha 1. Okay, so cholinergic agonists and cholinergic antagonists. You also say muscarinic antagonists or muscarinic antagonists. These are some of the drugs y'all keyed in on. Excuse me. So, and what you need to know is what is the gold standard, or what is the first line drug you want to give for certain situations? For people with pheochromocytoma, right? This is a tumor in their adrenal gland. It's pumping out norepinephrine. They get these episodes of just like tachycardia. They start sweating. You want to be able to block that. Now, this brings up an important point. So you may say, well, if you give a cholinergic agonist, why don't you just give an adrenergic agonist to counteract it, right? So if you give one parasympathetic, why don't you just give a sympathetic? You don't want to do that, right? Because you're pulling the body in both directions, right? You're trying to dilate your eye and you're trying to constrict your eye at the same time. You're not necessarily canceling it out. So what you want to do with these questions when they talk about an overdose, you always want to antagonize it. Remember that flat line on the curve, okay? You don't want to get a negative effect. You want to just get rid of the positive effect. You want to bring them back down to baseline. So it brings up an important point. You may want to get rid of the tachycardia, but you don't want to use a different pathway to induce bradycardia, right? Because you're telling the body doesn't know what to do. Do I increase the heart rate? Do I decrease it? So the goal is to, if there's any sort of overdose, you want to give the antagonist to whatever effect that is. Okay. These are some of the adrenergic drugs. Remember the sympathetic type drugs, epinephrine, dopamine, and you want to be able to know what the first line medication is for these. Sketchy has good, I don't know if y'all like Sketchy. Sketchy has good little videos for this. It's kind of a different way of learning. Y'all should try it out and see if you like it. For some reason, it just sticks with people because it's kind of a different part of your brain working. For the beta blockers, it conveniently works out that any of them named A through M are going to be selective. So atenolol, metoprolol, they're all going to be either beta 1 primarily or beta 2. The ones that fall in through Z are non-selective. So the beta 1 effect equals the beta 2 effect. So like propranolol is an example. So that'll help you break those down. So just little tricks we've learned here and there. So let's look at this. Atropine will cause dry mouth by inhibiting which of the following receptors, okay? So atropine is a muscarinic antagonist, right? So if someone comes in with some sort of muscarinic symptoms, they use the mnemonic dumbbells, you know, they're salivating, their heart rate's down, they have bradycardia. You want to give something to antagonize that, right? You want to try to bring them back to baseline. So you're gonna, so this is gonna be a muscarinic receptor. And atropine is the first line treatment for a lot of muscarinic overdoses. You see that with organophosphate poisoning. It's very similar. You wanna give atropine. All right, and you can see that here. Same thing, so you see this blockade. So if somebody comes in, their pinpoint pupils, or you can actually you can block it this way. So you can see these actions of blocking these muscarinic receptors. Okay, so typically you talk about overdoses here. All right, let's see this one. Good, right? And I know Lindsey, we all find this funny, and y'all it'll start happening to y'all when you read it, and then you're like, oh, she's got weakness, she's got double vision. You're like, I bet you she has myasthenia gravis, and then they'll tell you what it is, and you're like, man, I totally diagnosed it. So like that happens all the time now. So what happens in MG, right? So this is more of the nicotinic receptor, right? We're talking about in between the synapse between the muscle cells, right? So if you have this synapse here, these receptors here, you have this autoantibody, and this is the actual disease. They bind to these receptors, And that means when acetylcholine comes out of here, it has nowhere to bind. So over time, they'll say with repetition, that the patient comes to the office, you make them repetitively move their arm. And so you're actually filling up the very few receptors that are there, right? And then they get weakness. This is why they say during the day, they get more fatigue. They get drooping of the eyelids, which is called ptosis. And so what you want to do is you want to increase the amount of acetylcholine, all the acetylcholine you can put in this cleft here as possible, right? So you have all the possibility of binding as much as possible, okay? So what kind of drug do you want to do? Well, you can give an anticholinesterase or an anti-acetylcholinesterase, same thing. So basically, acetylcholinesterase is going to break down acetylcholine in the synaptic cleft. So if you inhibit the inhibitor, right? If you block the enzyme that's breaking it down, you're going to have more acetylcholine. So those few receptors that are available, hopefully the extra acetylcholine will help to bind it. This is very inexact. It doesn't work very well for these patients. It is kind of a miserable experience, but you know, it's something, right? So they're working towards fixing it on a more sustainable level. Okay, and we kind of talked about this, right? So you're going to give them an acetylcholinesterase inhibitor. So this will, at the muscle end plates, at that synapse, you're going to increase the levels of acetylcholine, right? So those few receptors that are not bound by those autoantibodies, those few receptors that are open, the acetylcholine can bind there. All right, and you can see this ptosis. Typically, it's a bilateral ptosis, just because over the time during the day, their eyelids get fatigued, right? Those receptors for acetylcholine, they're being overused. They don't have as many as you would like. So, and you can see that. See, they have this shallowing here and the decreased available receptors. You get into this in more detail next term, but for right now, this is what you need to know. Now, so in regards to the drugs, so what do you use for diagnosis? Edrophonium. Crazy enough, this works really well, but it works for like on the level of seconds, right? So the patient comes in, you give them edrophonium, they feel like $1 million for a minute, and then they like drop back into it, and it has such a short half-life. So unfortunately, the more long-term treatment that you want to give them is either neostigmine or pyridostigmine. Okay, so just remember that edrophonium, very short acting, you could diagnose them quickly, but on a longer term level, you want to give them one of these. I doubt they would give you both of the, like if they said what's the first line treatment for it, and they would put both of these as answer choices. Okay, so it's either one of those two. All right. First thing you should see here is a farmer, right? That's always how they phrase these questions. So if we look at this, and first off, farmers use pesticides, right? That's organophosphates. This is classic for organophosphate poisoning. It's classic. If you didn't know anything other than the symptoms, you could say all of these are parasympathetic type symptoms. Remember, I didn't point this out earlier, but when you're running from a bear and it's sympathetic, you would expect your blood pressure to be really high, right? This is not the case. So this is a parasympathetic response. It's a resting phase. Pupils are constricted. He's chilling, right? So this is classic parasympathetics. If you ever see a farmer, I promise you, every time it's going to be a farmer. They're the only people that use these, to my knowledge. And then you need to ask, what level are we affecting the pupils? So we know it's a muscarinic. And then you have to use that chart from first aid, the kick-kiss one, or kiss-kick, and you'll find that pupils correlate to M3. That's the receptor. Again, Sketchy does a really good job illustrating this. Okay, so yeah, I think first aid has it as the dumbbell symptoms, and you can look that up. But it's very similar. You'll see these are all parasympathetic type symptoms. Okay, so organophosphates, very similar. You could see this as an acetylcholinesterase inhibitor. Again, we increase the acetylcholine because we're not breaking it down, and you get these muscarinic symptoms. So whereas the difference here would be with myasthenia gravis, we're thinking about nicotinic symptoms. Remember, because it's a motor endplate. It's still acetylcholine. We still have a problem in the body with acetylcholine. This deals with muscarinic receptors. Myasthenia gravis is on the nicotinic receptors. So remember, nicotinic is muscular movement, and muscarinic is going to be that parasympathetic response. Okay, so treatment for this, atropine, right? We don't want to give something to counteract it. We want to give something to antagonize it. So if we have something that is increasing our muscarinic effects, we want to give a muscarinic antagonist, okay? All right, let's try this one. All right, so if we look here, parasympathetic, pilocarpine, parasympathetic is cholinergic, is muscarinic, right? Use these words interchangeably. As you do these, kind of work these out and say them like that, and it'll help you on the test. So parasympathetic, cholinergic, also muscarinic. We're thinking of rest and digest. You would think of more of a pupil constriction. Opposite being adrenergic, sympathetic, adrenaline, pupil dilation. You're running from a bear. You want your eyes really wide, right? You can see everything, hopefully. All right, and then you can see this is more about pilocarpine here. All right. Oh, this one's tricky. Yeah, very good, right? So I'll show y'all where this was in your notes, or where I saw it in my old notes. So we're talking about cholinergic, so we're talking about muscarinic, and you can see acetylcholine is used, and you could see that it's actually on the vascular endothelial cells. So it was actually here, you could see the M3 receptor vascular endothelial cells. So just a small point, but I found the question that correlated to it, and it was there. So just one of those things you should know. All right. Okay, cool. So nasal decongestant, maybe like pseudoephedrine. Ephedrine should key you in on maybe adrenaline, ephedrine, adrenaline. It's kind of in that same category, but it tells you straight up it's a alpha-1 adrenoreceptor or adrenoreceptor agonist. So adrenaline, right? So alpha-1, we did our thing, alpha-1, alpha-2, beta-1, beta-2, Q, I, S, S. Alpha-1 is Q. So which one talks about Q? GQ activates phospholipase C, increasing calcium, right? Immediately, as soon as you see this and you know Q, you could cross it out, cross it out, cross it out that it's between C and E. On the test, I physically cross things out. I use the cross out feature. I use the highlight feature. I use the flag feature. I try to do it all the same every time. If you get into a method of doing it, it decreases the stress, okay? So figure out what works for you, do the same thing every time. All right, again, we can see that here, the kick kiss, that'll help. Oh, and here's the breakdown from first aid. So GQ, phospholipase C, y'all remember it breaks to DAG and IP3. DAG directly affects protein kinase C, whereas IP3 will do calcium. And then you have the GS versus GI with adenylate cyclase, protein kinase A. So they have little mnemonics if you want to remember it that way. But by all means, make sure you know this. It'll keep coming up again and again. All right. All right, so let's look at this here. So contraindicated means you don't give it to them under any circumstances, right? So first thing you should ask, what do you give a kid with asthma, right? We talked about this. You want to give them a beta-2 agonist. That's what you give them. You're going to beta-2 agonist because that's going to open up their airways. If they have an asthma attack, they could take the albuterol, the inhaler, and it'll help to open up their airways. So if that's what works, you definitely never want to give them a beta-2 antagonist, right? Because that'll close their airways. You never want to do that. Now, as it so happens, remember anything from N to Z is non-selective. We said that A through M will select for either beta-1 or beta-2. N through Z for the beta blockers, that's OLOLs. They're gonna be non-selective. So this is gonna be a beta antagonist, right? So whereas you want to keep their airways open, right? This will directly close their airways more than it even is. So you definitely don't want to ever give them propranolol. So be careful because some people selected albuterol, but you need to make sure you read the question because they're talking about contraindicated. I know a lot of people, when it happens to me, when you get stressed out on an exam, you miss like the knots in the question, right? And you put what's positive and not the negative. So just keep this in mind. If you want to give an antagonist, by all means, don't give them an antagonist, right? Or if you want to give them an agonist, don't give them any antagonist. All right, let's look at this one. All right, so we want to look at these symptoms and we want to say, is it sympathetic or is it parasympathetic? Looks to me like she's running away from a bear, right? She's tachycardic, she's sweating. Look how high her blood pressure is. Normal's 120/80, right? So these are definitely sympathetic symptoms. I'm sure it doesn't say, but I'm sure her eyes are very dilated. Heart rate should be 60 to 100, it's 112. Respiration should be 12 to 16, it's 24, right? So a lot of sympathetic symptoms, a lot of adrenaline or adrenergic symptoms, a lot of norepinephrine going on. But then here's your key right here, and you want to keep this in mind. VMA is a byproduct in the urine of epinephrine and norepinephrine, okay? So what they're saying is she's making too much epinephrine and norepinephrine. So in adults, classically, this is pheochromocytoma. Okay, kids, they can have something like this. It's a neuroblastoma, but we talk about pheochromocytoma a lot because it illustrates this point. So if you're getting these adrenergic symptoms, right, adrenaline also, you want to numb those down, right? So you want to give some sort of adrenergic antagonists, right? Try to bring them back to baseline. And the first line treatment here, let's clear this, is phenoxybenzamine. It's a non-selective alpha adrenergic antagonist. So we want to antagonize all of those sympathetic symptoms, try to bring it back down to baseline. You can see that here. It's a tumor of the chromaffin cells, which are in the medulla, and it produces a lot of increased catecholamines. Okay, so just if you want to know a little bit about that, phenoxybenzamine for pheochromocytoma, that's a good one. I don't know if you really need to know that. Oh yeah, you definitely don't want to give them beta blockers first. Just a note here, because you could put them into hypertensive crisis if you block the beta receptors. So you got to give alpha blockade before you give beta blockers. I guess I don't remember exactly why I highlighted this, but maybe there was a question that I came across regarding this. Oh, actually, you know what it was? We had a beta blocker here. It's like, why don't you just give her a beta blocker and chill her out? Well, because you have to block the alpha receptors before the betas. That's why. Okay, we talked about phenoxybenzamine, pheochromocytoma. That's my dog snoring. She's bored, apparently, if y'all hear her. All right, and so this is classically, do y'all remember what this is called? This is Klinefelter syndrome. You have, maybe there was some sort of, it's typically happens in meiosis 1, because you get one of each of these. So 1X, 1Y, or sorry, well, total you get 2 X's and a Y. So you have a man, right, with the Y, but that extra X gives him feminine features. So as it plays out, he's going to have low testosterone. He's not able to conceive, right? Is the testicles are basically non-usable, right? So you have low testosterone levels. That's what you would expect, and you can see that here. Gynecomastia, so female characteristics, and infertility and testicular atrophy due to that low level of testosterone. So just some genetics in there. Like I said, I put on the first review, the way I remember this is if you forget the first X, you use the second X and you have one of each. So it's meiosis 1. I might be the only one that likes to remember it that way, but it helps me remember for whatever reason. If for some reason you had X, 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 or X, Y, Y, right? You get 2 of these or 2 of these, it's meiosis 2. Okay, it's just a trick. It's not gold standard. It's not black and white. There are some exceptions, but for whatever reason, somebody told me that one day and it clicked. All right, so, oh, and here we go. Right, so we talk about Klinefelters here, and yeah, like I said, so what are we talking about? Is it meiosis 1 or meiosis 2 non-disjunction? So this is how it should work. Remember, 2N mean that the 2 is referring to the colors, right? You have two separate full chromosomes, okay? So the original gamete or the original cell is gonna have 1 blue and 1 red. So then we're gonna replicate. So you have a 2N, meaning 2 of each, and 4C, 4 total chromosomes, okay? That's, or 4D, yeah. And so then they're gonna separate in meiosis 1, and you're gonna have 1N, right? 1 color in each. So 1 copy of both. and then 2C or 2D, we use D as the nomenclature, because you have 2 strands or sister chromatids, right? Then meiosis 2, you're going to split into gametes, 1N, 1C or 1D. And then fertilization, you get dads in there or moms, and that's the green one. That's how it should be. So if you look at non-disjunction meiosis 1, all 4 are going to end up in 1, and you're going to have an empty gamete, and then you're going to have them split like this. So typically you'll see with Klinefelters, it happens in meiosis 1, right? If it's a meiosis 2 problem, you see this work, meiosis 1 worked out properly. Meiosis 2 is where they didn't split. I wanted to point this out. A trisomy rescue is sometimes it happens, and you see this a lot with the imprinting, with when you have a uniparental disomy, when you have like Angelman's or Prader-Willi. So what happens if the cell recognizes, like right here, it has 3 chromatids in there, or chromosomes, it will actually kick one out. So sometimes you'll end up with 2 from mom. It'll just happen to kick out that 1 from dad. But I just wanted to point that out. That's the concept of trisomy rescue. But just in regards to the question, you could say that meiosis 1 was Klinefelter's. This was the problem here. But I still have to look at this every time I need to learn it. It's one of those things. It's just like, it's like the Krebs cycle. You learn it, then you forget it every time. So, all right, let's look at this. I assumed y'all did these, y'all did some of this genetic stuff already. We're almost done. This may carry over into next week, but I looked at your schedule and I thought y'all had done some of the genetics. So if this is a little strange to you, I'm sure Dr. Sobering will elaborate on it a little bit. Okay, I'll just share with y'all. So these are clinical symptoms of Edwards syndrome, which is 18. You should know chromosome 21, or a trisomy of chromosome 21 is Down syndrome. Patau syndrome is 13. So you have puberty at 13, that's Patau, P for Patau and P for puberty. Election, you can vote at 18, E for Edwards. You can drink at 21, D for Down syndrome. Okay, so you're gonna wanna know these symptoms. Y'all will get into this next week, I suppose. Right, so, and these are kind of how it works out. Y'all talked about Huntington's, those are those repeats, that concept of anticipation, and then maybe y'all will get into that later if y'all have it. Okay, and you can see that here, and what I explained, puberty, election, drinking age, these are just some of those trisomies that form. Okay, and this kind of just goes into meiosis 1 and meiosis 2. We won't harp on it since y'all haven't covered it yet. Translocation, did y'all do this? This is next week too. Okay, just some of the translocations, the problems that form. Classically, there's a 922. A lot of these cause cancer. So y'all are gonna learn about this. These are just kind of buzzwords that you can use. 922, 814 is another one. It's chromosome 8 and chromosome 14. You can get Burkitt's lymphoma. So these are just some of the classic ones. When those chromosomes rearrange, you can get some problems. Robertsonian, this is another translocation that involves that little nub. Some of the chromosomes have that little nub on the top. If those go missing, this is classically a Robertsonian translocation. Have y'all talked about DiGeorge syndrome? Yeah, okay, we can look at this one then. So this works out, the way to remember DiGeorge is catch 22. It's chromosome 22 and the symptoms are catch, cleft lip, cleft palate, atypical thymus, or thymic aplasia. I think I have a slide coming up. And then hypocalcemia is a big one. So that's what y'all will see in DiGeorge. Let me see. Here it is. Yeah. So this is what DeGeorge looks like. It's a problem with chromosome 22. But if you remember catch 22, you can remember it. Cardiac abnormalities, abnormal facial features, thymic aplasia, so they have a T cell deficiency, their immune system, cleft lip, cleft palate, and classically you'll diagnose them by getting a calcium level. You get hypocalcemia. And y'all will get into a lot of the details there later. Y'all did purines and pyrimidines, correct? Okay, cool. It's a pain because they mix it up. They mix it up a little bit each term, so I have to go back and modify these slides from last term, and yeah. So a deficiency in HGPRT, hypoxanthine guanine, something like that. HGPRT, that's Lesch-Nyhan syndrome. So classically, they'll talk about self-mutilation. If you ever hear that, it should be a buzzword for Lesch-Nyhan syndrome. They'll like bite their lip, they'll bite the tips of their self-mutilation. So yeah, so that's a deficiency here. You're gonna get hyperuricemia, and that's due to a buildup of PRPP. So that's going to HGPRT is going to break down PRPP, and if you don't have HGPRT, classically you get Lesch-Nyhan. You can see that pathway here. This is from first aid. All right, another one, ortic aciduria. So if you remember that ortic aciduria is part of the pyrimidine pathway, pyrimidine synthesis base production. So the pyrimidines we talk about are TC, and obviously for RNA it's going to be uracil. Okay, and that's just a jumbled pathway from first aid, but y'all will get into some of these drugs a little bit later. That'll be more important, but this is going to be one of the things you want to know. Again, when you look at this and you're like, what in the world do I need to know? Think about the diseases, think about some of the drugs that we talk about. Those are going to be the important steps, not necessarily being able to draw this whole thing out, right? Just the steps that are important. Oh. Okay. So how do we silence a gene? Remember, anytime you methylate it, you're going to silence it. Methylation and deacetylation. It's going to silence it. You're going to make heterochromatin. So methylation of cytosine molecules, right? And deacetylation. To make it euchromatin or transcriptionally active, you're going to demethylate it and acetylate it, okay? So this is the methylation process. You put big methyl groups on top of it. You can't really transcribe it, right? They're big bulky, or not really, but they're in the way, right? On the DNA. Then acetylation, remember, if it's deacetylated, it has a, if it's acetylated, it does not have a charge. So it's not going to bind to the DNA, okay? So it has a neutral charge if it, make sure I get this right. If it's deacetylated, it's charged, okay? So the DNA, the negative DNA could bind the histones and it'll wrap up. If it's acetylated, it's neutral. It's not going to bind the DNA, so the DNA is going to be transcribed. So remember, methylation and deacetylation is for heterochromatin or silence. Demethylation and acetylation is for euchromatin or transcriptionally active. We went over that in the last review we did. All right, last question. Excuse me. What are we talking about in multifactorial inheritance? Right. Yeah, right. Okay. So we're looking at Mendelian inheritance, and that's just the process that we see. You know, for better or worse, we've all developed through evolution. It's a multifactorial process. This is Mendelian inheritance. Everything's not straightforward. Many factors come into play into developing you as the person you are, And so we look at this in a Mendelian inheritance pattern. And this is classic for this multifactorial. So, you know, we talk about this in med school and it's really straightforward. This person has low calcium, they have the George, but in real life, the values are all over the place. And that's why we go to med school and we learn these things so we could be amazing doctors. That's all we have. Y'all could find everything on Scrubs. We'll try tentatively, we'll get another review in for you guys before your exam. So we'll stay, if y'all have any questions, I'll post the review, the recording later for you guys. But if y'all have any questions, we'll stay.
There was
very much.
There was one last question in the chat that I'll just open it up. The difference between acetylation and methylation and all of those things.
Yeah, so methylation is going to be on the actual DNA. If you methylate the DNA, you're going to silence it. Acetylation is going to be on the histone. Remember, when you silence the DNA, you wrap it up in the histone to make it compact. So when you deacetylate it, it's going to be charged. So it has a positive charge, DNA has a negative charge, so it'll wrap up. If you acetylate it, you're basically taking off the charge. So the histone will not be charged, therefore it won't bind the DNA, so it can be transcribed. So methylation is directly on the DNA, acetylation is for the histones. Y'all can snap a picture of this as well. It's access to the Google Drive, but the link's on the Scrubs page too.
We have another request to go over the AM selected versus NZ non-selective with regards to beta blockers.
Oh, it's just it's easy mnemonic to remember. Any of the beta blockers that fall, the first letter of it fall between A and M are selective, meaning they'll work better on either beta 1 receptors or beta 2 receptors. They select towards one. Any of and that's like atenolol starts with an A, metoprolol starts with an M. Those are selective, right? Anything that goes from N to Z, such as propranolol, right? P falls in that range. They're non-selective. So when you take that medication, they work on beta 1 receptors and beta 2 receptors equally.
I have a quick question. Is there any way you can go over that question that the incidence was 1/3600? I'm kind of lost when you multiply the half and half and you got quarter.
Okay, yeah, sure. And that part is a little bit more complicated than I think they'll actually, then they would give you on the exam, but yeah, I can take a look at that.
Before we go that, I'm going to verbally address a question. I had a question about how do you address FTM1 cumulative questions? I don't study them because the cumulative questions are going to be very, correct me if you think I'm wrong, Brady. They're more basic than they were when you took the original content exam. And it's going to be like the big things. They're not going to get a nitty gritty detail. They're going to be something that they really want to harp on. So I never go back and study for the cumulative questions.
Do you think go over the quiz going to help us?
Going over what?
The FTM1 quizzes are these?
Yes, the quizzes, weekly quizzes we get if we review them.
I mean, it couldn't hurt. It couldn't hurt for sure if you're going to do something from FTM1 just to check. But I'm on the same line as Lindsey. Like it's just so much material. Like a lot of the cumulative questions are things that'll carry over to FTM2, right? So that'll be so that'll carry over. So and they're pretty straightforward. So the idea of spending so much time going back through that stuff, I just never did. So
thank you.
Yeah, focus on the FTM2 stuff. The other stuff will be, the cumulative stuff will be straightforward. Okay, so let's look at this. We had an aunt and a sister and a husband, and they had a child. Did they say what the child was? A niece. Well, let's make her female. There we go. Right. So she was a carrier, right? So she was A. So what is the possibility? So we were trying to figure out for this lady here. And again, this will probably be more complicated than y'all need to do on the test because obviously y'all don't have scratch paper. But if we have one big A and one small a, this is not X-linked, right? It's autosomal. So what are the chances she got the small a from mom, and what are the chances she got it from dad? It's 50-50
from each one. Yes.
Yeah,
Okay,
exactly.
so that's how
right.
you got it. Okay, perfect.
Yeah, right. So half from each, right?
Yes.
And
okay.
so we want to know, okay, here are the parents. Now we know siblings, fraternal, or not twins, but siblings are going to share half their DNA. So also for this aunt of interest, there's a half chance she got it as well, okay? And that just works out because they're sisters. So you multiply it through. So it's 1/2 times 1/2. I put this on here. Lindsey and I were actually on the island briefly. So we got a little bit more in depth when we did these. We had to actually do, use the whiteboard when we did them all out. But so whenever you do this, you multiply through. So then it's 1/2 times 1/2. If you're still a little confused, you can actually just do the Punnett square for each of the parents and stuff, and you'll see that the numbers work out equally. But you just know that it's a 1/2 here, and then if you look at the parents, they'll have 1/2 of the DNA there and multiply it through. So that's how you get the 4th.
I am kindly
Thank you.
I'm gonna post some of I posted it really early in the chat, but that's a really long way to scroll it. There are a few videos that helped me a lot in conceptualizing the receptor stuff and the ANS stuff. Unfortunately, with the receptors, there's no shortcut. It's really just rote memorization and memorizing it, honestly, unfortunately. But to understand it, I had some videos that I really liked. I'm gonna post them in my group, Dog Mom DES, so you can just click the link and go to them.
And everything y'all need to know, if this, like I said, this is probably a little bit more difficult than you'll need to do in the test, but definitely check out these links because Dr. Sobering goes through all of these here. So everything you'll need to know. This is specific for the online curriculum. So he'll walk you through this stuff so that if you could do these without scratch paper, you should be good to go.
I have a question.
Yep.
I'm kindly asking if it's possible, if you go over the question, why we give the patient the phenoxybenzamine?
Yeah, sure. So I think that was the patient that had pheochromocytoma. Let's see.
Like, I'm sorry to make you go back again.
No, no worries, no worries. That's fine. Here we go. Yeah. So yeah, so this woman has a tumor that's causing too much sympathetic activation. So you need to give her something that's going to antagonize or decrease the sympathetic activation. So you're going to give an alpha antagonist, and phenoxybenzamine will do this. So these will help to bring these sympathetic symptoms back down to baseline.
Okay.
Okay.
Thank you.
No worries.
I just want to thank you guys for the great session. I attended few of these past few weeks, and some of them by respect I have to leave because I feel like it's a waste of time, and some of them they got me more confused. So today I came with a hesitation, but it was a time very well spent. You guys are very fluent, have a great control, and have an amazing way of transferring this. So please let us know every time you have a session. This was amazing.
Thank you. We appreciate that.
Yeah, I'm glad it was helpful. You will always find us posting on my page is Dog Mom DES, Brady is Scrubs DES. We always share each other's posts if we're doing one of these reviews. So if you just follow both of our pages, you will never miss one of our reviews.
Perfect. And I was heard that you guys gonna have another one next week, correct?
Maybe next week or the following week. We're going to definitely try to get at least one in before your exam, before your FTM2 exam.
Perfect. Thank you so much again. You guys are amazing.
Yeah. Whenever we're knocked bogged down with our test studying, we're going to try to do reviews for you guys. This helps us to keep it at the forefront of our minds. So
thank you. No, you guys are amazing. Have a wonderful weekend.
Yeah, we used to actually do PLGs as well, but it's because we're doing these reviews for term 1 and term 2, and it is cumbersome for the weekends for us. We're going to strictly do it this way. So all of our review signups will be on our pages. And again, it's not affiliated with DES, but we obviously cover the same
Perfect.
material.
Perfect. Thank you. Because your confidence definitely transferred to us. Undergrad, my GPA was 4.0, but here I did few quizzes and I didn't do very well. So it took my confidence. And I was talking to Dr. Nilu yesterday that when I see material, I get really panicky and I get nervous. He told me no. So that's why it's important when you go to places that people are confident and they are relaxed and they teach you things like is smooth, like a ballet dance. So it was great. Thank you very, very much.
Good. Yeah, the hardest thing about medical school is you have to learn how to do the questions, because these aren't just straightforward asking a question. These are clinical vignettes that you have to kind of decipher some of this information. And a lot of times people will do poorly, not because they don't understand the information, but because they don't know how to decipher in a vignette. And it takes some practice. It really, really does. So that's a big thing.
Yes.
And there's definitely a benefit from peer-to-peer learning, right? Like some of the doctors have been doing this for like 50 years and they can't even it's just difficult to speak on our level. So the fact that we've just gone through this just makes it all the better. But yeah, we'll post it for you guys whenever we do our next one.
Thank you. Thank you very much again. I appreciate it. Okay. Thanks. Bye-bye.
Okay. If that's it. Oh, go ahead.
I know it's been a long session. I was just wondering, like, for the drugs, how did you guys get the drugs down?
Memorization.
Just straight up memory.
Yeah.
Honestly, there's no shortcut. So what I did, and I just posted the video in my Facebook group, one of the videos has this, I'll actually show you the picture. I'm going to share my screen real quick. This is what I want to share. This little guy, I screenshotted this and I drew him. And I drew him, I did all of the receptors, and then around it, I wrote out all of the drugs with respect to the receptors and everything. I love whiteboarding. I always say that. And this really helped me draw out this little guy, the receptors, and then putting the drugs around it in the little categories for all of the receptors. And then honestly, just repetition. You like read through it, you close your eyes, you try to repeat what it is. And then, you know it really well when you can close your eyes, you can repeat everything. And then you can go to a clinical vignette, see a clinical presentation and go, oh, that's what that is.
Gotcha. I actually did the drawing thing for just like the receptors to kind of get them in my head because I was just like having the worst time with that. But yeah, I think that's a good idea. I'm gonna do that with the drugs.
Yeah, unfortunately, there's no shortcut. FTM 1 and FTM 2 is so much rote memorization. Like when you get into more CPR, MSK is a lot more rote memorization, but like CPR and beyond, you can get very conceptual with it and just understand it and then fill in all of the nitty-gritty details. And that's what Brady and I preach all the time is, first going through it, you just want to understand it. You want to know what's going on, and then you can fill in everything else. FTM, unfortunately, is a lot of rote memorization, and there's not a lot of conceptual stuff with FTM.
Yeah, when we first got it, I was like so overwhelmed with it, and I was like, oh my gosh, how am I gonna do this? And I like freaked out. Like I was just so overwhelmed with it. But I think like the repetition really helps. So today is much better than 2 days ago. So I feel better, but I have to get all of this down. I know a lot of people feel that way too.
Yeah. And it's funny because Brady mentioned towards the end of the review, like someone said something to him and all of a sudden it clicked. Like that's sometimes what happens. Somebody will tell you a way that they memorized it or a little acronym or analogy, and it just clicks and you're like, oh, that makes sense. And you never forget it after that.
And like, I could just say in regards to the drugs, like categorizing them, any of the drugs you could put in the same category, it'll obviously make it helpful. And obviously some of the drugs have the same ending, like OLOL will be all of your beta blockers and stuff. So use whatever you can to your advantage towards it. But yeah, anytime you can compartmentalize things into different categories in your brain, that'll help you with that.
Yeah.
All right, I'm gonna go ahead and stop the recording. If there's anything else, guys, we'll stay back and answer questions. If not, you're obviously free to go.
Yeah.